Okay, thanks everyone for joining us for another edition of Discussions in Diagnosis. This morning, it's my pleasure to welcome Dr. Ian Neeland, who's from University Hospitals right here in Cleveland, Ohio. And Ian is the Director of Preventive Cardiology, as well as co-director of the CINEMA program, the Center for Integrated and Novel Approaches to Vascular Metabolic Disease. So welcome, Ian. Thanks for joining us this morning. And we're going to talk about coronary calcium scoring. I feel like we just had this discussion yesterday, but we're going to do it again today. So thanks for joining us. So to start with, for those who are unfamiliar with it, could you talk a little bit about CAC scoring, how it's done, and why calcium would serve as a useful marker of cardiovascular risk?
Sure. So coronary calcium scoring is done with a CT scan. It's a non-contrast CT with very low radiation, about 1 millisievert, which is about the same as a transatlantic flight. It's done in a radiology suite. There's a software that's used to essentially take cross-sectional imaging through the entire heart and overlay an algorithm to look, and so calcium pops out as a color. The radiologist then circles each calcification, and the program gives a number, a score. It's called an Agatston units, and that's named after Agatston, who was the South Beach diet, I believe. And he was one of the people who was instrumental in developing this technology and this scoring system. So we now have a score that's given, and the report is given by vessel, each epicardial vessel, and then there's a total score. And the calcium score started around 1992 by a company that was called, I think, HeartScan America. And they purported this technology as being the next step in risk assessment. And it was about the early 2000s, when the cardiology community, in terms of research, really got involved in doing this and looking at this on a larger scale in multiple cohorts, both here in the U.S. and in Europe. And the first reports showing that coronary calcium scoring could improve risk assessment in patients for atherosclerotic cardiovascular disease came around the late 2000s, about 2008 or 9, I believe, in New England Journal. So, it's been around for quite a long time. But once, over the years, once the initial report was given, so, it's been developing, and more people have looked into coronary calcium scoring and how it's related to other risk tests that we do or might not do. And it's become the most important risk assessment tool outside of the standard risk calculator that we use in cardiology, and I believe also probably in primary care as well. So it's the other thing is in university hospitals is that we have a no-charge coronary calcium program called the Clarify program. And I believe it's the only one like that in the country. I think we have over 100,000 scans that have been obtained since the start of this program. And my colleague Sudhir Alkindi and Sanjay Rajagopalan, they lead that program, and it's a wealth, a treasure trove of not just of population-based coronary calcium scoring data for research and for development and new ideas. So it's quite a powerful test, and happy to talk more about it today.
Sure. Yeah. So tell us a little bit about what are the scores like? What's a good number? What's a bad number? What comes out of the test?
So the scores that you get really range from 0 to no limit. I've seen calcium scores 3, 4, 5,000, and the basic way that we stratify the numbers, 0 is clearly normal, and then you have a 1 to 100 or so. That's what we call relatively low risk, and then 100 to, some people say 3, some people say 400. That's kind of intermediate, and then 400 and above is more high risk. As you can see, if you're the 400 and above is a much wider spectrum, right? You can go all the way from 400 to 5,000. So the number itself means something, but always in the context of the patient, other risk factors in the patient's situation otherwise. So for example, a patient with many risk factors and very high risk by a cohort equation risk estimator with a calcium score of 0 will de-risk to some degree, but it's not like a guarantee that the risk is all the way down to low risk. And then on the same way, if you have a person who is very, very low risk, let's say 0.5%, and they have a calcium score of 50, that up risks to some degree, but it's not all the way to high risk. So it's very informative. It can move the needle, but it's most actionable in the intermediate risk patient, where the person is essentially on the fence to start statin, aspirin, other preventive therapies. Blood pressure also weighs into blood pressure treatment also weighs into the full cohort equation risk, and calcium score may help with that as well. But it's that intermediate risk patient, usually between 5 to 7.5%, sometimes up to 10% or so, where the actionable decision making occurs, and that's where you get the most bang for your buck with this test.
Yeah, that's a great point, Ian. So, I mean, in general, and we'll talk about this in a future session, diagnostic tests are most useful in people with an intermediate pretest probability of disease, and calcium scoring is a prototypical example of that. Can you talk a little bit about its superiority in using, compared to using just the typical ASCVD risk factors or calculator alone? Because that's what most of us do.
Yeah, sure. So there was a very nice study by Joseph Yeboah, who is at Wake Forest, and he compared, at that time, he compared the Framingham risk score, which was the one used before the PCE kind of came out and was took over in terms of popularity. And he compared Framingham risk score alone versus multiple different cardiovascular risk tests that included coronary calcium, ABIs, FMD of the brachial arteries, high-res CRP, family history, carotid IMT. And what he showed was basically essentially did a C statistic or area under the curve for each test in addition to the Framingham risk score, and showed that far and away the coronary calcium score outperformed and out-discriminated the other tests in addition to Framingham risk score. And there's several examples now of that, but that's a very nice example to show that many of these tests that we use in the community may not be as helpful or useful as we think. And so if we're going to choose a screening test to do in the appropriate patient, coronary calcium is certainly the most impactful screening test to use.
That's terrific. So we've talked a lot about the advantages of coronary calcium scoring. Can you talk a little bit about the limitations? Because we get concerns about calcium metabolism, people who've been on statins. What are the limitations of this test?
Sure. So, the one thing I like to talk about patients and counsel them is I get a lot of patients coming to me that had a calcium score, and in their brain, in their mind, they think that they have stenosis and they need a cardiac catheterization. And I try to explain and counsel them that's not what it shows. The calcium score is definitely not looking for obstructive coronary disease and stenosis. And so what the test is essentially the presence of atherosclerosis and the process that's been started that will certainly increase over time, and therefore it portends increased risk and need for preventive and aggressive preventive therapies. So the first thing I do is say it's not stenosis. Okay, so but the process is there. So how do we understand that process? Well, some of the limitations of calcium scoring, for example, are you can still have soft lipid-laden plaque. That's the unstable plaque that could rupture and cause MI in even the presence of very low calcium. Although, from a probabilistic standpoint, the risk is extremely low. So there is a very tight correlation between calcium burden and the number and risk for type 1 MI. But again, you can have people at either extreme where they may have an event at a very low calcium score, and they may never have an event at a very high calcium score. So that it's not just this is going to happen to you tomorrow. People say, am I going to have an MI tomorrow? No, that's not the situation. Another thing to think about in terms of calcium scores is, and I think I mentioned this yesterday, was a lot of people say, well, if I'm on calcium supplementation for bone health, for example, osteoporosis and such, so maybe I shouldn't be taking that. It's causing more calcium. The answer is that there's no direct connection between those two things. Certainly, there is a relationship between systemic and vascular calcifications across all the arterial beds and coronary artery calcium. So, for example, in patients with end-stage renal disease who have a lot of vascular calcification, they'll usually have very high coronary artery calcium scores, as I mentioned yesterday. And then, people who have, for example, high calcium scores may also have calcification in the aortic annulus. And so you may see something, a mention about that on the scoring sheet about calcification in the aorta, and that's related to or correlated with aortic stenosis in the correct clinical setting as well. And we actually use calcium scoring of the aorta or the aortic valve to help determine whether or not someone may have aortic stenosis in certain settings. So that's actually another use of the calcium score.
Now, is that routinely reported then when you get a CAC score? Or?
I think, well, so it's not part of the routine unless you see it, and they may acknowledge it or mention it. But probably if you see a severe amount of calcification, and then the patient may describe symptoms or even potentially asymptomatic, getting an echo would be the next step for that.
Sure.
But for example, in low flow, low gradient paradoxical aortic stenosis, where patients have severe, it looks like severe aortic stenosis, but normal gradients or normal flow. So often we'll get a calcium score, and there's cutoffs actually for men and for women to help determine whether or not aortic valve surgery is helpful or not for that patient. So given whether it's real. So that's another important point. For calcium scoring, also we tend to look at the overall score more than the individual scores of each vessel. I don't make a whole lot out of, if it's predominantly in the LAD versus, multi-vessel. Obviously, the more calcium burden of atherosclerosis, the higher risk. And so if you see it across all, arterial beds, then there will be obviously a higher risk. Another calcium score conundrum is what to do with the score in terms of additional testing, right? So this comes up very often, and there's been studies looking at this. And my general approach, and this is, I'll caveat it by somewhat evidence-based and somewhat practice, art of science, the art of medicine based, is for people with a calcium score over 1,000. If they're asymptomatic, I may do a treadmill stress test on them. The reason being that at 1,000 and above, the risk for multivessel disease and therefore potential need for CABG, not for symptoms, but for mortality benefit, is higher. So I've caught several patients in the thousands where they've had multivessel disease and gone for bypass surgery for mortality benefit, even in the absence of symptoms, or at least overt significant symptoms. On the flip side of that, for people who are 100, 200, 300, I will not do stress test unless they're symptomatic. And if they're symptomatic, they probably shouldn't be getting a calcium score as the initial test. It really should be a functional test or a coronary artery angiogram to work up those symptoms of angina and for obstructive disease. One place where a calcium score could be helpful, and it's actually now in the guideline, is very low risk chest pain. So very low risk chest pain where, normally you would just basically say, you're low risk, there's nothing else evidence here, we don't need to test. So the guidelines say you can either not test anything, or you may do a calcium score. And again, if it's 0, then the risk is incredibly low and it can kind of rule that out. So that's part of the guideline now, actually, calcium score for chest pain, but only in the very low risk cohort.
So if I understand you correctly, if you have someone with a score in the thousands, the likelihood of multivessel disease and even possibly stenosis is quite high. Okay. Yeah. So again, you have to put it in the context of everything. So, but I'll usually I get several of those referrals all the time, and I'll usually do a treadmill test, which is, if you think about it, right, is cheap, it's easy, there's no radiation, and what will give you is global ischemia, right? If it's very positive on a treadmill, then more likely to have global ischemia and multivessel disease, and more apt to then do more testing for, to diagnose that. The other part of calcium scoring I think is important to know is the following. So if a person's already on, let's say, a high intensity statin, and their lipids are fine or borderline controlled, there's probably not a good utility in doing a calcium score at that point, because it's not going to give you more actionable information beyond what you already know and what you have. Plus, we know that statins actually can stabilize unstable plaque, which results in calcification of the plaque and increasing calcium scores. So there's definitely a correlation between going on a statin and higher calcium scores, both for age and also because of the statin.
So it's going to give you conflicting information. You're going to say, well, oh my gosh, the calcium score went up, but I'm on a statin, is not working. But it's not. That's not the situation. It's
Mhm.
different. And then the other case is patients who are like in their 60s, 70s, 80s, certainly the greater age. If you just do a cohort equation on them in a risk study, they'll probably meet criteria for statins, and the calcium score probably won't be helpful again because they're in the high risk cohort already. So that's another piece of advice.
So let's talk a little bit about sort of the motivational or demotivational value of CAC scoring, because I think this is really interesting to those of us in primary care and others as well. So, for example, the patient who has multiple risk factors but has a CAC score of 0, or someone who is relatively healthy and we get a CAC score and it's high. And can you talk about what impact that has on patients' behavior and risk?
Yes. Yeah, so there's been a fair amount of study for that specific question. You could refer to studies by Karim Nasir, Mike Blaha, and the de-risking is part of the guideline in terms of a patient with intermediate risk who has a calcium score of 0. There is a degree of de-risking to the point where certainly if the patient's on the fence about statins, for example, that may be sufficient evidence to hold off for a while, and then reassess. In the other situation where if we have a very low risk patient with a plasma calcium score, so I think it depends on the number, right? If it's mildly elevated, probably doesn't increase the risk sufficiently to the point of action. But if it's extremely elevated, then certainly you have to think, well, first of all, you got to think why this person who's otherwise very low risk has significant calcifications, but two, it might rise to the level of action to the intermediate risk. There's a score actually you can do online called the MESA, coronary artery calcium score. It's basically similar to the PCE plus the coronary calcium score, and will give you both the kind of baseline risk based on risk factors, as well as if you added the calcium score in. And it'll actually go both ways. If it's a lower score, it may actually de-risk to some degree if you have a very high baseline score, and then vice versa, it can up risk. So that can give you some, information that's evidence-based, based on the MESA study, to tell patients. But again, it all comes down to context, and I think, putting everything into the risk factors, the calcium score, the patient's willingness to go on statins, and any contraindications for that, all kind of plays into the general decision making to do it. In general, statins are very safe. I do want to make sure that's front and center in terms of people's minds, because the data for statin myopathy is more and more showing that it's there, but there's a lot of nocebo and placebo effect. And so if you compare it to a placebo, there's very minimal increase in the general population for significant muscle aches to cause symptoms. So in general, statins are very safe. They're in most people, they're well tolerated, and the risk for diabetes, for example, which always comes up, is the number needed to harm for diabetes for a statin is 250. So if your number needed to treat to reduce one event, ASCVD event, is anywhere below that, so then the risk benefit, at least for diabetes, is in the benefit side. And then again, the cognitive dysfunction questions have essentially been dispelled. There are people who will report it, but from an evidence standpoint, and that hasn't panned out in terms of studies. So that's a good point too.
That's helpful to know. And actually, UH and myself and Kelsey F. Holtz are involved in the Preventable study, which actually studies the impact of statins on cognitive function in older individuals. So the last thing I wanted to talk about, Ian, is where do you see the future of CAC scoring? What can we expect over the next 5 years?
Yeah, so I think these big registries like the Clarify registry will be really helpful to define and discern where we go next, and looking at other populations that might benefit from coronary calcium scoring, going beyond what we do standard right now. One example for that would be patients who have elevated LP(a). So, you have a 35-year-old individual or 40-year-old individual who their parent had early onset heart disease, and they have an elevated LP(a). So there's some data that coronary calcium scoring can help, even if the patient is otherwise low risk, right? And it's just the LP(a), that calcium score may be helpful to add that to the Lp(a), and if it's elevated, to then treat with statins. And we don't yet have Lp(a) agents; they're in the works, but that's one niche area that's talked about. Another area of interest is familial hypercholesterolemia. So guideline would say that if you have an LDL cholesterol of 190 or above, that's called severe hypercholesterolemia. The person may have familial hypercholesterolemia, depending upon other historical and exam findings. But if you do have the severe hypercholesterolemia or FH, there's a controversy of whether, if you're very young, let's say you're 20. So obviously you go on a statin, but is there any utility, for example, in doing a calcium score in such a person that we should, to change our goal, right? So should we just treat down to an LD of 100, or should we treat down farther to 70 or 55, based upon someone with FH who's extremely young, whose risk over lifetime is high, but in the short term is not as high, and they're already going on a statin? Does the calcium score help, that in terms of aggressiveness? That's another niche area. And then we have the calcium score can be done here at UH by itself or with a coronary artery angiogram. And the field is moving based on the most recent chest pain guidelines. And I think there was a lot of political lobbying from the CT community for this, more towards use of an anatomic test like CT coronary angiography for chest pain evaluation over a nuclear stress test, for example. And the reason for that is it gives you, the nuclear stress test is a functional test. Will tell you if there's ischemia from a lack of blood flow to a certain myocardial segment, but it won't tell you the anatomy of the vessels. Whereas a coronary CT angiogram will actually give you anatomical information and stenosis information that can be actionable and can help if you say if you have severe disease, go to a cath and then confirm that. So the field is moving towards coronary CT angiography, and here when we order that, you get a coronary calcium score as well as the CT angiogram results, and so that's being added. And I think over time also, the last thing is that I would say about the coronary calcium score is that, as I mentioned, is looking at calcification, but doesn't necessarily tell you if there's lipid-laden plaque, which is high-risk plaque. But people are trying to then use special, radiomic approaches to the calcium score, and people are doing it here in our department to look at high-risk plaques. So can you not just give a score, but can you also determine if there's a high-risk plaque or a low-risk plaque to help understand risk and aggressiveness for preventive therapies?
Wow, fascinating stuff, Ian. Thank you so much. We have a few minutes left. We're going to throw this open for any questions or comments from our group this morning. Please make sure you unmute before we do that. Give folks a second here. Well, yeah, it looks like you answered everyone's question already.
Everyone's an expert.
Wait, I have a question. No,
Okay,
I'm just wondering,
please.
hi, thanks, Ian, for that, Deb Lies, and I appreciate all the consults too. I've had a number of patients have these coronary angiograms, these CT over the last month, these CT ones. How much do they cost? I was just wondering.
How much they cost?
Free. Yeah.
I don't know the answer to that. Probably several $1,000s. And if they utilize that CT FFR, fractional flow reserve with heart flow, then the cost is going to be even greater. That's a third-party company that they actually send the images to. They do an analysis and send back the information. We add to the report. So, yeah. Yeah,
we're starting to just see a lot of people having them, and I was like, ooh, that's a guy that push is definitely there. Yeah. Yeah,
I don't know that it's probably a little more than a nuclear stress test, but probably not that much, I would guess. Because that still requires, an agent, a pharmacologic agent, a radioisotope, and such. But the one benefit of a coronary CT angiogram now in 2023 versus a nuclear test is lower radiation. Right. It used to be that the CT angiography was done retrospectively, so they basically did radiation throughout the entire scan, and it was higher. Now what they do is gating, where they only do radiation in between a certain part of the cardiac cycle where the heart is the most still. That's in diastole, the last third or 2/3 of diastole, and they only turn on the radiation there, and then they piece all those together. So the radiation now is much lower than a nuke. So not as low
Wow.
as a CT coronary score, but again, it's much better. So that's, that the field is getting moving more towards that anatomical assessment than nukes.
Thanks
Thank
for
you.
the question, Deb. Any additional questions? Okay, if not, thank you so much, Ian. Fascinating discussion this morning. Look forward to hearing more about it, and look forward to seeing everyone again next week as well. Please have a safe day out there. It's some snow and rain coming to Cleveland and perhaps where you are too. So stay safe, and we'll see you next week. Bye-bye.
Thank you very much.